It's a great question.
Hi.
Yeah.
So I'm Shubhangi and I will be presenting the paper later. I have a question with regards to the generic drug. So when the patent for the expensive drug is about to expire and we are about to launch another one, if FDA comes into place, then what would be the impact on the existing drug, the generic drug in the market? Because if FDA is regulating both the drugs, so what would be the parameters for judgment of the already existing generic drug?
So that's another very interesting question. Most of the time, any kind of a comparative judgment just leaves the existing drug well enough in the market and just says, well, this one is better, this one is worse, and the approval for the original, the off-patent drug is not pulled, even when a brand withdraws the product, right? Unless there's some safety and efficacy problem with the original product. So all you have now is maybe the generic's ability to come in still, but with more information. It can say, okay, there's this new drug out there, but the original drug is just as good or no worse. Generics can already do that. They just aren't good. They don't do a ton of advertising because they're not built to advertise. They could already say that the original drug is just fine and you should continue prescribing it. I think my proposal maybe gives them tools to make this easier, right? It's like kind of with a black box type warning or a clear statement that it's not worse. You can just point to that and not do a ton of advertising. But generally speaking, the original drug is still okay to market, with one exception. So if the new version has such a different risk-benefit profile that the risk to the old one is no longer justified, then maybe the old one will be pulled. The classic example of this would be abuse-resistant opioids, right? So when the original set of opioids were approved, people knew that there was abuse potential, but the need for them was so strong that they're allowed to be in the market. I mean, to be honest, the abuse resistance problem was underestimated, but also when the new version came on with these coatings that prevent you from kind of abusing the drug and so on, the FDA actually pulled their original version and said that it's no longer, given the approval of the new one, it's no longer safe to market the old one because the risk benefit has changed so much. But it's rare to see that, and usually the old drug just stays in the market. And what my proposal, I guess, does is to make it easier for the generics to convince doctors and payers to continue to prescribe the old off-patent drug, because it's still, the approval has not been lost and generally will not be. Is that helpful?
Yeah.
Great. Yeah.
So I'm Akshat and I'm a fourth year law student. My question to you is basically that what's the implication of this issue on a market like India where commercial advertisement of pharmaceutical prescribed drugs it's almost non-existent and it's almost banned. So specifically in Indian jurisdiction, the pharmaceutical industry is not supposed to advertise their drugs to the end consumer directly, right? So what's the impact of this study on that, and like how does that affect your study?
No, I think it's a big part of my proposal that this in a soft switch case, advertising plays a large role, and some of it is direct to consumer advertising where a push is created onto doctors. Now, I think you can still have a product cop without advertising, and that is when you withdraw the original drug from the market. Right? I assume you can do that in India even now, although it may run into competition law problems or something like that. So, and it's hard. I mean, that kind of an aggressive strategy is hard to deal with. Now, I think part of my proposal is to counter advertising, but part of it is to generate information. So advertising aside, if you're in a jurisdiction like this where you can't advertise, but the government agency can still say under my proposal force you to generate comparative information, I still think it has some positive effects. It's just not as positive as in the U.S. where you have to affirmatively counteract some of its advertising. So I think actually in some ways the proposal is more likely to work in a jurisdiction like India because there's not such a strong commercial free speech sort of protection to advertising where the information is just be out there, it'll be fairly neutral and won't be as much noise to contend with. So maybe there's less necessity for the proposal, but if it is adopted, it's more likely to work because there's not much to counteract. So that's very interesting. I didn't know that. Thanks. Yeah.
First of all, thanks for this enlightening lecture because I'm not from IP and Health. I'm an economist.
Okay.
So I learned a lot.
That's great.
There are a few questions that I have. First one is, like what is my takeaway from your discussion is that your focus is essentially on first of all product hopping, then is information asymmetry, and something you said in the beginning about social equity versus the free rider problem, right? Now, whenever you're discussing the product hopping problem, first thing that comes to my mind is that what I have understood is that you're saying that to apply for the secondary patent, the pharma should have improved substantially on the drug.
Mm-hmm.
So why not introduce it as a new brand altogether if it's a substantial improvement? So why does it have to be a continuation of the old brand first? Second thing, what is the objective of the study? From whose lens is this study being done? Is this through the lens of pharma or FDA or the consumers? Because once the decision is there that who are we concentrating on? What's the end goal of the paper? I think then it becomes very easy to then channelize what kind of solutions can be offered. Because if you're looking it through the lens of pharma, I think I agree to what Sunita also asked, why will pharma comply? And now the proposal that I am giving for that, why not apply for a new brand patent at all? So FDA may want to do it, but the pharma will not comply to that as well.
Mm-hmm.
So what stops FDA from doing that? Because yes, of course I understand that there is pharma lobbying, but FDA should technically be authorized, the regulatory body has the ability. And if the end goal is the consumers, then I believe that there is the question that you raise of information asymmetry. That is the key question. That the dissemination of information, even the dissemination of the information on comparative data, how simplified it is for the consumer to reach. Because that, and while your discussion you were talking about, at the end of the day we also agree that doctor prescribes the medicine. But if the end goal is social equity and the consumer knowledge, then I think there has to be a methodology for dissemination of information for the consumer.
Right.
And especially in the age of internet, I don't think that's a very difficult thing to. Yeah, I think largely these are my questions.
Yeah, no, these are excellent questions. So this, the interesting thing about the new brand is that I think the pharma companies are trying to kind of have it both ways in terms of the advertising strategy. They want to say that the new product is not so different that you should consider it a whole new drug and completely reevaluate prescribing it as a physician. But at the same time, it's different enough that you should adopt it instead of the old one. So they're trying to have it both ways. And I think the FDA, again, when the FDA approves a new drug, it doesn't distinguish between how it's branded, right? So the branding is really largely up to pharma, and FDA can say, well, this is a new drug, and then pharma will shape the presentation of the data and say, okay, well, it's just slightly different, but it's different enough that you should be prescribing it. It's not, not so different, not such a new brand that it will require a full reevaluation from physicians or something like that. So I think kind of new brand versus original brand is not really within the FDA's purview. It's really how the drug is marketed. Now, I don't think. The improvement I look for is not so substantial to be completely changing the drug. It's just I want some information, even if it's something as trivial as people forget the drug list or something like that. It's still the same active ingredient, same more or less brand, same drug, but it just has a slight tweak. So I'm not necessarily interested in a big improvement. Now, if the improvement is substantial, a drug company I think can market it as kind of revolutionary change. But I think the fear is they want loyalty to their drug, and once you open an inquiry to say, well, this is a completely different version that's available, maybe the doctors will start looking broader in the market to other potential sources and intra-brand competition. That's the tough thing, and what your question raises is really interesting. It's in the competition is within the same. What is a competition within the same company like when the same company offers two products? How is it better to brand it? And I think it's a really tricky point. If your brand is substantially different, maybe you're opening a door for intra-brand competition. So you want the market definition to be just so narrow that the market is basically that company, but not so narrow that it runs afoul of antitrust law or something like that. So they're in this really strange squeeze, and I think it's their incentive to say that the change is not that substantial, but that it opens up inter-brand competition. So I think pharma can do that, but I think it's risky for them to do it, and the FDA doesn't really control branding in that way. As to your second question about the end goal, and I hope I answered that. We can continue to talk if that does that make sense as an answer to your first question?
Yeah.
More or less. So your second question, and that is, I think the FDA's role is, I keep calling them an information intermediary, but the role has to be sort of a translational role, and there has been some effort into sort of using the product label as translating information from sort of scientific back and forth between the FDA and the pharma brand into usable information for consumers and physicians who don't have as much time and so on. And they've had even sort of training and initiatives. And now, not all the data that will come through will be laid out there on the label, right? It's not necessary, and some of them might be trade secrets, right? So the FDA's job would be really to, it's almost like you draft patent claims, it'd be drafting kind of pharmaceutical claims, right? They'll work together with the brand and say, is this supportable? And is this sufficiently accessible to be useful to the audience, which are doctors and payers ultimately, and even patients. So the FDA's job will be, and this is something the paper touches on a little bit, but maybe sort of almost the next paper. How does the FDA translate scientific information that it's crunched through?
Yeah, so I think my query is largely this only, that why is the data not simplified?
Mm-hmm.
Why is the information not simplified? And put it out there for the end consumer, not for the patent lawyers or that kind of information I'm not talking about. I'm talking about the end consumer.
Right.
So it does not mean that they have to list all the components of the medication, right? But at the same time, what is the improvement, if improvement at all? So how will it? And that takes from whatever you said, that if there are clinical trials, then they can say, yes, this is better than the other one because it has been tested on so many, such a sample of so many people and this and that. So yeah,
my only hunch, if I can just improve it, I think going that way would be a little complicated in practical terms, simply because it shifts. In healthcare, the physician is the choice architect, like you just mentioned, right?
Yeah.
So you are now, with this way of regulating, of course it's information, simplified, it sort of then shifts the burden away, or rather the decision making to a large extent can be then it's great if you are talking about specifically highly efficient medicine way. So it's a physician's role to inform about these are the choices, this
but
is
that
the benefit.
is, I think, the question.
So once you put it as a proposal, it seems to bring in transparency, but I don't see it as a business strategy to be adopted in.
Of course. That's why I said, what is your end goal? Is it the social equity that we're talking about, or is it to have a good business strategy? So as a business strategy, this will not function because, of course, as you said, physician is the choice architect. But this is where the problem also exists. The asymmetric information exists because of the intermediary who is the physician. So if the end consumer has enough knowledge, then the consumer himself or herself can say that I think I will prefer to take a generic, which is cheaper.
But you cannot put that kind of onus on the patient. You cannot.
No, but that's what I'm saying. I think
practically
can
accepted,
debate it
right?
with the physician.
Yeah.
The information will help in.
Wait, you can answer just after.
No, go ahead, please. I think I'm just remembering. So the rule that the FDA developed, I think they're called physician labeling rules. So the idea is to empower doctors. Even for the doctors, some of this is too much.
Right.
So the idea is largely to empower doctors, and maybe equally trained professionals on the payer insurance side who can process this information, because even doctors now can't. I mean, the level
Yeah.
and the obscurity, let alone the end user even. But it still, I think, gives a big role for the doctor.
And I think while you were presenting, you also mentioned that even the doctors, they think, okay, this is the most costliest medicine, so this might be most effective.
Sure.
And I think that is where the problem arises, because, and this is what the information asymmetry will lead to. I mean, it leads to already doctor being misinformed, and because there is a business strategy by the pharma where MRs go to the doctors and yeah.
Well, it's almost an agency cost problem. The doctor's not
Exactly.
being a good agent.
Yeah.
No, because the doctor should be patient agent, but they're being their own kind of self-dealing agent and says, well, what do I do to limit my malpractice liability? So I guess that's where the payer comes in, and in a good system, I think a payer will be a market check on that agency problem and say, all right, you're engaged in self-dealing. Ultimately, of course, payers self-dealing in their own way, right? But they're there to control costs, right? If they said if you're imposing costs on the system just to protect your own back, that is a problem, right? So I think you're right. No player in this market is innocent, and they all have their own interests
I
in
mean,
mind.
I'm just trying to say
Yeah.
that probably empowering the consumer
Yeah.
with information.
Yeah.
It does not take away the physician's role as a choice architect.
Right.
It just enforces, a patient becomes an enforcer of good medical practice.
I see that, and the question is, how do you make the label accessible to patients? So it's funny, right? Just the timing of it, right? You, as a patient, you see the label after you've gone to the pharmacist already, but there's some aspects of the label that you are required to discuss at the prescription stage, and that's usually black box warning, right? So even though the patient sees the entire label after they've gone to the pharmacy, the doctor must at least discuss the black box warning. This is a really serious side effect. So one small part of the paper, and maybe I should remember a little bit more prominent, is I thought that to empower patients, this kind of cost comparison or comparative analysis should be essentially kind of a new black box, or black box too, so at least the patient has some knows why am I being switched to a new drug? Because that's almost a moral issue, right? If you have a drug that's working, right, and the doctor wants to prescribe a new one because maybe they've been convinced by advertising, maybe there's malpractice liability fear, or maybe got a free sample or something like that. But the patient at least should know that, and if the black box says, there's no comparative information, so the patient can ask them. The patient can understand that, right? And so, why are you prescribing me something and switching me off of a regime that's worked so far without any proven benefit? As I can see in this box, we had 3 words: no proven comparative, 4 words: no proven comparative benefit, or something like that. So I think I do want to use it somewhat as a patient empowerment tool. The question is how. And it's funny, the FDA is focused on mostly doctor empowerment, but I think the black box is one area where it's shifted to patients.
I mean, I'm glad
Yeah.
that there is a black box in the US, because I'm not, at least I'm not aware if it's in India at all. Because we are not, at least in practice, we are not told that why this medicine will cause this side effect or something. Nothing like that.
I mean, doctors are given broad latitude, but black box is one area where you have to. Yeah.
Look, Professor, my name is Dhruv Shekhar. I'm an alumnus of the law school, and I'm presently working with the legal counsel for an organization called Common Cause. My question is a bit clear and deals with what Professor Ashita spoke about. So you'll have to bear with me a bit. So you have the concept of bioequivalent studies, wherein the drugs, or rather the generics, have to be similar in the most important way, and perhaps the differences are most trivial, right? Now, my question deals with the aspect of black boxing and how consumers psychologically perceive these drugs. So in all respects, when you have practices like product hopping, do you think there needs to be a discussion on how, let's say, the dyes which are used, the color of the particular generic, those are the particular kind of things? Because ultimately, since even when you, I was just looking at a recent estimate, it stated that the contribution of generics to the drug industry was perhaps just within the range of 11 to 20%, whereas your branded drugs were taking the remaining chunk. So that's a huge amount, even though there is a greater degree of information which is there in the United States. So would you recommend that, in terms of how the drugs are manufactured, as well as particularly the dye which is there? Like, I was reading an interesting case pertaining to chloromycin, and how a writer for a publication called The Atlantic spoke about her experience, whether she decided to go for the generic or the branded. So, I mean, like how, because in India, like she mentioned, we don't have any of these kind of discussions even taking place. Like it's less averted with respect to this issue. So, how would you recommend tackling that in the United States?
That's interesting. So I think people have held on to the branding part of it. If for some reason there's reason to believe that like a brand has better manufacturing practices than the generic, some doctors will. Sometimes it's purely hunch or habit. But they will still hold on to the brand, which is more expensive, and it's the FDA's job to check good manufacturing practices and so on. But sometimes they fail, or again get information that's less than perfectly useful. So I think the branding actually helps, whether it's rational or not, right, for doctors and maybe even patients to make those similar kinds of decisions, but even maybe less defensible in some ways. I mean, they're supposed to be chemically equivalent drugs, right? They're supposed to be completely interchangeable at that point, and but the branding still gives some differentiation, right? So it's funny, they invent names for the kind of the genus, the new chemical name, and then they're all fanciful names, so the brand versus generic. And I think it's meant to protect, that aspect of consumer sovereignty, I guess, if a doctor decides for some reason, or if a patient wants, again, to at the cost of a higher copay to say I want the brand for whatever reason, they can do that. So I think that's where the branding comes in, is not be completely interchangeable. Even though the default could be interchangeability, the consumer or their physician can step in and say we don't want that, and that maybe serves as a secondary check on kind of good manufacturing. And sometimes you have situations, and again, medicine is so much about hunches, right? You have an inactive ingredient that doesn't affect therapeutic equivalence or bioequivalence that causes an allergic reaction or something in this one patient, and you want the ability to prescribe the brand because it's already worked, even if it's more expensive. But I think that's the role of branding. So you're saying in India that's not you're not allowed to do that kind of branding. It's between sort of generics and brands.
The usage generics in India is very limited. From whatever I've read so far,
It's a lack of information.
It's lack of
information.
No, what has happened,
Oh, interesting.
Pretty much
actually you're talking about
You just
something I'm
can't brand
researching on. India has been great at exporting generics
Generics,
rather
yeah.
than having local
like
consumption.
China.
Okay. And the trend is, and in fact there are OECD studies looking at generic adoption. I think generic adoption is maximum globally in the United States.
Oh, interesting.
That's very interesting, actually.
Oh, okay.
speaking.
Well, there's no generic substitution.
Can you believe
Yeah.
it? Yes.
That's so interesting.
That means, and that's why they are probably the highest generic importers for India as well.
So the US is really the consumer of
44%.
That's really interesting.
That was very exciting for me because when you start looking at dependency and third world blah blah, when it comes to generic markets, the question changes.
So India actually doesn't consume generics as much as it produces them.
But our President Prime Minister, he started this scheme called as Jan Aushadhi Center. So I don't know to what extent that has been effective in terms of.
No, we'll have to check that.
Yeah.
You're right. Also, the source of information of that
Yeah,
is
exactly.
also just Niti Aayog, which is
That's really
the government think tank, not an independent body.
I was also curious about the role of pharmacy, at least in US, because here, as long as the pharmacist convinces the
Yeah.
patient,
Yeah.
this is a similar
That's
drug,
Oh,
this
interesting.
can sell
So
them
then this is exactly, I think, the information asymmetry and the use of heuristics.
Mhm.
That is what is causing the cognitive constraints, and that cognitive constraint is not only among the patients, it's also with the doctors.
Yeah.
Because the MRs, the way they advertise, that is how because your cognition is then anyways
And
limited.
even to a
So-
certain extent, see, if you take an example of this university itself, you just have one pharmacy. You go to them and you ask them for a particular prescription also. They'll say, I don't have this, but I have a substitute. Now you have the convenience of either buying here or going somewhere outside where you might or might not get that drug again. So you will choose to buy the substitute anyway. So that kind of a role that pharmacy plays in India, does it happen in US too?
So the substitute is not chemically equivalent. It's just the pharmacist says it's close enough, and you're allowed to do that, huh?
Lots of people
That's interesting.
they trust the
By the way,
chemist.
I don't know how much are you interested, but Competition Commission actually released
I
a
know
proposal
about it,
for you
yeah.
to, if you want to take an empirical study to look at this problem, go ahead for it. Yeah, I mean, I might just share that link with you. No, the intermediary problem is actually interesting. I think it was 2018 January that I came across the Deloitte supported report explaining why are list prices, I mean, increasing, decreasing, something like that. So it was, I think, stable. Major US companies, list pricing was stable, increase were around 10%, which is predictable, right? But the problem, the new way of looking at it was the intermediaries' involvement in the R&D has increased. So it's just not the R&D by the pharmaceutical companies. You have benefit shares like insurance companies now investing in it, and therefore the cost eventually increases. The distribution channels change. You might have pharmacies relying, again, the same thing, the marketing, who is able to include or use the networks like that. But I think his proposal specifically is to check the one who can regulate, right? And that is the best way to go ahead. I mean, otherwise,
so
like he's mentioning, the problem is it will become an antitrust problem. How do you remedy an antitrust problem, right? And then who's paying the compensation for it? It is the taxpayer.
Exactly coming to that. So Dimitri, I don't know if your focus is the consumer, but if it is, I think the way the argument can go about is this only, that the consumer itself is a taxpayer and research, like the research is funded through the government. So the taxpayer is funding the research for these drugs. So the least that can be given to the consumers is an empowerment tool.
So
to check this. So I mean, this is just a suggestion. I mean, further you'll have to see how to go about it, or if you really want to go about it at all as well.
But I love the agency cost framing, because that's really what it's about ultimately, right? Everyone is out there for themselves. And the consumer, I mean, the research, some of it is government, some of it is privately funded, but obviously, at least the doctor's a fiduciary to the patient, right? But it's interesting that the consumer, the pharmacist, can make these changes, because in the US what happens is compounding, so some of the pharmacies are allowed to make kind of end stage manufacturing changes that are not affecting FDA approval, but they can still affect something, right? It can still affect, and they're allowed to do that. But the fact that a pharmacist can sort of change at the point of sale, that's interesting, because as a patient, by that point you just want your drug, like you've already gone to the doctor, you already scheduled it. You don't want to have that multi-step search for a new drug. So that's interesting, and like how much a pharmacist can do. I think in the US, they can pretty much, they have to either prescribe it as written or substitute as allowed by law or mandated by law, but they can go outside the bounds of that. But the pharmacist is still not there for your interest. The pharmacist is there for the insurer's interest, frankly. In the US, they're not out there looking out for the patients. They're there to minimize, and often there's vertical relationships, right? CVS Caremark in the US would be an example where they have a formulary and they're there to manage costs for the insurers. So it is interesting to see, but they're definitely not for the patient. So who is for the patient? It should be the doctor, but often the patient lacks the empowerment to deal with doctor's own self-dealing, I guess, is the issue, right?
This actually raises another
Okay.
it's not a question, just a thought. Okay, actually when you're talking about that the pharmacists, how they're catering to either the insurance company, but not the patient person. In India, I think it's slightly different. In India, pharmacists do actually recommend, okay, if you want a generic, I can give it to you. Okay, so I think that's got a lot to do with the culture so it's just a thought out there that how even the medical practice is embedded into the culture of the society.
So the pharmacist can be your neighborhood. It can be your neighborhood shop or something like that. Because pharmacists, I guess I've gotten used to some people at my CVS, but it's not like a neighborhood experience by any means. But like the old school pharmacy, which are in the US largely disappearing, maybe are still present here. And it's like you can buy other things, you can buy milk or whatever.
That's more of a pharmacist come general store rather than a pharmacy.
That's right.
Taking the Indian society into consideration, I think giving the information about, giving a more amount of information about the drug itself is rather detrimental in the Indian societal structure, specifically because of the illiteracy and because of the societal condition over here, that if you give them access to a lot of information, they just keep popping pills. I don't know, it becomes.
I think it's the
But you
opposite.
don't have to.
It's not really that. I don't think so, because I've seen so many people who just.
No, but they can't pop pills without
Yeah.
prescription.
Yeah.
Anyways, like technically they cannot.
But
Practically, I think
I
that's not
feel
what's.
practically
God,
the
this is really
available
your paper.
information
That's interesting.
See, your paper has generated so much enthusiasm.
These are cultural questions, you should look into it. But if you're going back, I think 2 years or 2014, CUTS had, along with CCI, come out with a report on this aspect of pharmacy involvement. Okay, you should look into it.
Okay.
And it's easy to make a general statement about culture without looking at the epistemic studies. So OECD comes out with country-specific studies. OECD, I mean, India is not a part of it, but India is working very closely because now we are co-chairing G20. You should look up these and then come out with these
So what
observations.
does the study actually talk about?
It's generally speaking about health equity in various emerging economies. And that's where you look at these cultural behavior of patients versus, of course, physicians' role. You're talking about patients' illiteracy. What about physicians' lack of knowledge? Right? So there's a lot of problem in that sense. But again, dependency, who is regulating this? If you put everything on the Competition Commission, I know everybody is a fan of that economic regulator, but I also know they are not equipped to answer these questions. That's why they send out these calls for you researchers to take up their job. But yeah, it's interesting. Look into it. It's always better to find something out there and then critique. So I think we'll leave it that. Let's take a short break. The students, scholars, you have 7 minutes to present. Yeah, be very pointed, only important bits, so that we can just generally look at the problem and ask you to see it in ways that help you get the publication out. That's the point, right? Student, do we need a break?
Should 5 minutes, I guess?
Yeah. Let's take a 5-minute break, please. Thank you so much. It was brilliant.
Thanks so much for all your great questions.
We can always press us. All right, go ahead.
Good afternoon, professors and everyone present here. My research endeavor primarily deals with the dichotomy of access to pharmaceutical innovation as against the pricing and the compensation which is being received by the investors in these pharmaceutical innovations that are taking place. So, firstly, to establish the objective of my study, it is imperative to recognize that to exhaust an innovation to its utmost practical potential, reasonable access to the same is imperative. And an exorbitant monopoly-oriented pricing can be highly dangerous to ensure such an access, especially in a patient-driven market. And my focus upon this is specifically on the developing economies as against compared to the developed economies like the United States. So over here, through this paper, I tend to emphasize upon the existence of regulators which prevents highly exorbitantly priced drugs to enter the market and reach the target public, which in fact is detrimental to societal development, and I'll show as we go along, specifically in the case of India. Further, the one main thing which I've tried to bring out through this research endeavor is that there's a difference between a consumer-oriented market and a patient-driven market, which has not been recognized by the investors in this particular economy. The investors who are investing upon these innovations tend to ignore this fact while setting prices, that the patients are not fortunate enough to choose as a consumer, and the market more often depends upon needs rather than wants. So thereafter, I look at a contextual analysis of different economies and the jurisdictions, and I base upon a differential pricing model where I propose a state. Further, certain pricing models will be analyzed across the world that have been adopted to effectively ensure affordability, and the best possible suit specifically for India is being proposed by me through this particular research endeavor. So, going forward, firstly, I would like to start this. All this is being done in the context of the CAR-T drug, which has come as an immunotherapy mechanism. So, cancer, as you all know, lacks a magic bullet, specifically in developing jurisdictions, because there's no certain cure as to how to remove the menace of cancer totally. But a lot of research organizations, specifically in the United States, have come up with this technique called immunotherapy, which involves a 3-step procedure where they extract the immune cells out of one's body, re-engineer them, and then put it back in the person's body. And this clinical trials have proven this method to be quite sufficiently effective in removing the menace of cancer totally. So the investment of this drug, the investment on this drug is increasing gradually, and specifically 2 companies have been granted the market presence, specifically in the United States, called these companies are Novartis and Gilead Sciences, and they've respectively brought in Kimbria and Yescarta. As we go forward, the methodology which I followed in this particular paper is that firstly, I trace the commercial investment which is being done by these investors upon this particular technology. Thereafter, I'll analyze their pricing mechanisms and models which are being put into specifically in the United States. Thereafter, I'll go on to analyze the cost and price difference, the cost which is being incurred by them and the pricing which is being carried forward by them towards the consumer. And then I'll do a cost benefit analysis, and from the perspective of different stakeholders, that is the consumers, the regulatory agencies, as well as the people, as well as the investors. I'll also emphasize upon the drawbacks of this technology to show as to how such a high pricing model cannot comply with most of the regulatory bodies. Thereafter, I have proposed a way forward in a long-term as well as a short-term perspective, and specifically thereafter dealt with the Indian economic mechanism, and I have specifically stated the factors which ought to be considered while setting a price in India if this drug is to come in India, and thereafter the various pricing models which have been employed elsewhere will be analyzed from the Indian perspective. So firstly, the investment statistics. A lot of companies have started investing in this particular technology. Started with Gilead and Novartis, but Juno Therapeutics and Selectis are the 2 more coming forward investors. And specifically AbbVie, it's a very recent phenomenon that AbbVie has invested along with the Caliber into the switchable CAR-T technology. So CAR-T is basically an individualized procedure wherein every single individual is treated separately. Their own immune cells are taken. So there's no off-the-shelf provision. It's individualized, but AbbVie has come out with this new technology and invested in this new technology wherein off-the-shelf provision is being made, which is a significant technological development as it kind of reduces the prices, because a single manufactured procedure is much more expensive if it is done every time for an individual customer, right? So this off-the-shelf provision is another technological development which has been invested onto but is not present in the market yet because clinical trials are still going on. There are different pricing mechanisms which have been followed, and specifically by the 2 FDA approved investors in the United States include Novartis and Gilead Sciences. And they both are not competing against each other because the present industry is kind of different. Novartis deals with adults with acute lymphoblastic leukemia, whereas Gilead Scientists, Novartis deals with kids and young adults, whereas Gilead Sciences deals with adult patients only, specifically. So the competition in the market is still non-existent because of them dealing with different patient bases. So Novartis is charging a whooping $475,000, whereas Gilead Sciences is charging $373,000. And the justification given by them for this pricing is that it is based on the value which is generated by the society. That is, there being no other certain cure. The price is a human one. Basically,
This price is per?
It's per customer. So it's an individualized treatment, right? So the customer needs to pay this much, and this is apart from any other logistical cost. This is just for that. The hospital fees, every other logistical cost is separate from this, right? So the justification for this particular price is no alternative being there, and empirically impressive outcomes have come out of clinical trials, which is allowing them to charge such a price and has been approved in the United States. Novartis also has come up with this outcome-based model, which is basically based upon the pay per performance criterion, wherein as per within a month, the time limit has been given to be a month. Within a month, if the cancer relapses, then the person does not have to pay. I'll be looking at this model in depth a little later. So coming on to the cost price difference, it has been claimed by Novartis that the cost for this particular drug is over $1 billion. Whereas a lot of NGOs have given this empirical data that because of taxpayer-funded technology being available to these research organizations, it's not really that expensive to produce, even though the manufacturing cost is there. So there's a thin line of alteration, but the line of alteration still persists and is present over there, which is being ignored and falsely represented by these companies. Thereafter, in the United States, there's a relatively free market, so the regulatory agencies like FDA, they allow certain drugs to come, but there has been instant refusal of this particular drug
to enter in the EU. That the NICE organization has clearly rejected the entry of this drug from the side of Gilead Sciences because of the high prices, which is basically the consequence of this is basically non-access to the people of that jurisdiction to this drug, which is again detrimental because they don't get access, they can't treat their cancer with a certainty. Coming to the Indian perspective of this, India has one of the highest number of cancer patients, as empirically I'll show in the next slide, as to how in India there are a lot of cancer patients who don't get any access to treatment, and with certain technology being present over there, just because of the lack of affordability, they don't get access to these medicines. Yeah.
So Novartis, what is the cancer treatment? Which kind of cancer is Novartis providing treatment for?
Lymphobatic leukemia. It's the lymphoblastic leukemia. It's for the kids and younger adults. Right.
So the Indian patient number that you just quoted as
Yeah.
is for that.
Yeah. It's combined for all for the patient base of Novartis as well as Yescarta.
So
As
what
well-
is Yescarta providing?
Gilead Sciences,
So
right?
the sum of the cancer
Yeah.
patients in India
Yeah.
is specifically for those who are expecting treatment for those kinds of cancer.
Right.
Are you sure?
Yeah, right. So basically, in India, the generic figure of cancer, of the number of cancer patients is really high, because of which a lot of people in the
That's great
yeah,
information. I know it.
yeah,
I'm not challenging it.
right,
If you compare it with the most populated versus the least populated, you
Right.
will find cancer is the menace.
right,
I get it.
Right.
I want to know, when you're saying Indians suffer with cancer most globally,
right.
so you're talking about Indians suffering with this cancer that the treatment is provided by Novartis/Gilead. Is that what I'm
The point which I'm trying to make, ma'am, is that in the United States, certain pricing is being permitted because of them being capable of paying that particular amount, right?
I'm
In
talking
India.
about affordability, I'm talking about the number. See, it's easier to quantify.
The patient base is not, even though it's not similar, the point is,
No, this is important for clarifying your research. Because
Right.
otherwise this course is really, you're making too many variables,
right,
right?
yeah,
So if you're making a statement that India, this is a problem for India,
yeah,
you should narrow it down and be specific, this is a problem because these many patients expect the treatment for this kind and only these two big companies can provide and the pricing is a problem for that.
Right.
Anyway, the pricing is, you
Right.
don't have to say it is a problem. I
Right.
mean, it's not sustainable by any means.
right,
And I know you're going to argue United States found a way and UK found a way, but we'll have to investigate in which way. So,
right,
so something that I could get from the way reading, and this is just from your question.
Right,
That's why
right.
I'm asking you to just don't give me facts which don't matter.
right,
Give me facts which are actually being targeted in your way.
okay, right,
That's it. That's the question. Keep that in mind. It'll help you polish your argument.
right,
So that's something I want to know. I don't believe that's the number. That's what I'm saying.
Right.
I'm saying that I don't have the numbers right now in my hand, but that's definitely not the number for that specific answer.
okay,
Okay?
Right.
If you want, we Google it.
But I thought, taken from there only, I don't think it is given any number.
right.
But that is what is a bigger problem. You just said a lot of people.
Ma'am, the number will be
So
represented
that's
next
easy to
time.
find, but you can say that India versus Canada, right?
Right,
And the justification is most populated versus least populated, or at least scantily populated. So that's your point of actually bringing that number in is because is that a policy problem for India? Yes. And then is there a solution? Yes. Then therefore the problem lies in affordability, right? That's where your pricing strategies will play in.
yes,
Otherwise, it's a very big health access to health problem for any cancer suffering country, right?
right,
We will go specific to fact. That's what I'm saying.
right,
I'll interrupt you later, but I just wanted to ensure that you don't consider us as we don't know the problem. We
Right.
know the problem. We want to find out how much are you able to add to this argument.
right,
So that's the way.
right. So, as in the case of EU, Novartis has cut its price by 23% flat to get the regulation which is being intended. So, the point which I'm trying to make through this is that in the regulatory agencies are considering a contextual analysis which is not primarily being entered by various investors in this company. They are just putting a similar price tag in every jurisdiction without taking into account the context of the socio-economic structure of that particular jurisdiction. So it's highly imperative for them to do so. Thereafter, I would like to get into the cost-benefit analysis of the difference between aspiration and achievement. The high prices have been the justification of high prices which have been given by Novartis and Gilead Sciences as a human one involves a major fallacy that is the same which I've been discussing since the beginning. That is the difference between patient and consumer. They have equated the concept of a patient with a consumer without considering the question of needs and wants over here. So the various models, the justification of various models which have been given, outcome-based pricing, it is a pay-per-performance model, but has no proximate connection with the pricing of the particular drug. So it's not reducing the price in any way, right? Plus another major issue with outcome-based pricing is that it's a 1 month period which is being given, right? The 1 month period is a really short time to judge if the cancer will relapse or not. A 1 month period, if your cancer relapses after the 1 month, this model does not apply. So which is a highly detrimental factor of this particular model's application. Thereafter, insurance coverage is not given at once. It's a co-pay mechanism, which is highly detrimental in the case of certain drug which is so highly priced, where it is important for the insurance companies to know that if such a high price is to be sustained, then they need to provide a full-fledged one-time pay and then seek the payment somehow later, right? So that needs to be understood as well. Further, there are certain drawbacks of CAR-T which are being highlighted. Like CAR-T has life-threatening side effects, which is contributing to the reluctance of various jurisdiction regulatory agencies in accepting market entry of these drugs. Where even low IP filings have taken place in this particular technology has taken place due to the low mitigation mechanism prevalent. Further, kill-T switches are being brought in, that is off-the-shelf provision is being brought in by companies like Selectis and Belicium for more control, but the point is, it has not reached the clinical level yet, and it's taking place, but the point is, you are pricing it so high, you need to understand that there are certain drawbacks which need to be taken into account when you are pricing the drug in a certain way. So the way forward basically is that the ICER report has also recognized that inadequate exploitation is taking place due to affordability concerns, and there's a need for effective payment and delivery mechanism, including insurance cover and provision of additional discounts. So I've proposed a 3-step model: effective pricing models, technological adaptations like the one which is being taken place by abou of off-the-shelf provision, and an effective insurance cover. Coming to India specifically, so the market presence under similar conditions in the US is totally unimaginable due to the socio-economic condition of India. Further, the Indian lower and middle class, it's unaffordable to them. There's a majority population which suffers from this menace, and it's unavoidable for them to seek this particular treatment, but they can't do so because of the high prices which are associated with them. So the context of a developing country needs to be accounted for, and a differential pricing approach where richer nations are subsidizing the poorer nations needs to be taken into account by these investing companies. Further, a strict price cut and control mechanism repels investors. So the regulatory agencies also need to liberalize their conduct, as a strict price cut and control mechanism repels investors to invest in the market itself. They'll feel that there's no incentive for us to invest in this particular market because of the low compensation we are receiving. So it's important for the regulators also to liberalize to a certain extent as to promote a lot of investors to come in, and then the competitive forces to take place. So as long as reasonable price is being charged, some price is being cut down, certain models are being given, and on the other hand, regulators are liberalizing to a certain extent, quicker entry comes in place, which fosters more competition. So as soon as competitive forces start acting place, the price automatically gets regulated to a certain extent. So penetration of price control drugs in the rural industry is important, but it has been noticed that since price control has been taking place in India, 75% of decline in investment is taking place, which is basically the cause of the investors repelling from Indian market, which in turn reduces access to these kind of medicines. So the long run way forward in the Indian perspective is a relatively liberal regulatory mechanism, quicker standardization of prices through quicker entry, right? So if quicker trials take place, quicker entry takes place, quicker competition takes place, and the prices get standardized because of the enactment of the demand and supply forces. Thereafter, an experimental and liberal market space in the beginning is imperative for a sustainable accommodation of these prices. These are long-term solutions, but what about the short-term affordability concerns? So here, the 3 models which have primarily been used in other jurisdictions are outcome-based model. I've already discussed the shortcomings of that model, specifically in the context of India. The value-based model, that is actual value generated to society. Now this model is really inadequate in the concept in the context of India because firstly because of the lack of a reimbursement mechanism, because insurance companies are really reluctant in India. There's empirical data to prove that insurance companies have not really showed an intent to reimburse fully in a very high priced drug, specifically in India. Thereafter, there's lack of adequate data. So because of diverse perspectives being present in India, there's lack of adequate flow of information as to get to know as to what the value is actually in actuality being generated of the particular mechanism. Further, an EMI based model has been proposed, in which an easy installment mechanism is being proposed for, but this has not been tested yet, specifically in the case of India. So the recommendation which I am trying to bring into this paper is a hybrid model combining of an EMI based model along with an outcome based model, which will basically remove the 1 month deficiency of an outcome based model. The point being that if every month a certain amount of fee has to be paid for this after reduction of prices, this model will remove the 1 month and the outcome based model removes its 1 month feature. Every month certain amount is being paid, and once a relapse takes place, you can just stop paying then onwards. So basically the pay for performance model acts in a more effective manner, and it reduces the one-time burden upon the consumer, which will incentivize them to further invest, and the insurance companies as well to further provide such insurance cover for these medicines and pharmaceutical products. So long time period to assess results and benefit, and respond with an option to pull out of payments if unsuccessful results at any stage. Further, a very important thing is collaboration with financial institutions, funding mechanisms, and certain governmental interventions, which is imperative in this particular situation because of the right to health, which is under Article 21. It's important for the government to recognize this problem of access and provide for certain incentivated benefits, and to provide for subsidized to invest themselves and provide for subsidized rate to the end consumers of this particular drug, which is necessarily important for the society. So the question which I am bringing forward through this is the requirement of brainstorming some liberalization and low profit orientedness of the pharmaceutical industry as compared to a general consumer based industry. So it's important to brainstorm upon how much liberalization is to be done, how much profit needs to be cut by, but the point is this needs to be recognized that these two solutions need to be taken into account while going forward in this particular and market, and promoting more access and investment in drugs which are not really generic but which are new to the society with new innovations, so that they can reasonably be accessed by diverse population in different jurisdictions. Thank you.
Bring the data history as common data first, and then I'll do the
Right.
let's see that way. And then anybody who's on. You can reserve your responses if you see uniform response.
Right.
Remember that this is not a place for justifying; it's more clarification based.
Right.
Also. And take even if you don't agree, put those points down.
Right.
So I said, ask somebody to take notes. Or if somebody is giving a reference that you're absolutely unaware of and you don't think it has anything to do with it. Like ma'am is an economist, so she might just
Right.
put somebody giving a reference. Right? So then you should be used. That's the reason why they do it.
Right.
I have a question for Vijay. Any questions which were made during the presentation? I have a question, I have two questions which I want to ask.
Yeah. So before we go,
Yeah. Okay.
so you have to have the comment and the question here.
Okay.
And you read first. And good that you have shared the data.
Yeah.
Yeah.
Okay. So the first question I have is why would the company, the pharmaceutical company, when they had in their clinical trials, showed such legitimacy for their drugs, would want to extend the 1 month period? Because even though 1 month period is less to check for the relapse, but why would they want to extend? What is their incentive? And is there any case which in where the cancer relapse, and what was the company's response to a claim after that? Because for instance, after just say maybe the 30-day period ended and 2 days later the cancer relapse, so what was the is there?
So that's what the empirical data suggests, that there have been cases where cancer has relapsed after the period of 1 month. That's the issue. The problem has been recognized in consonance with the empirical data, and the problem is that because cancer does relapse after 1 month, That is why this model is not seeming to be sufficient, and the investing companies have straight denied as to the application of this model after the 1 month period. So it's basically a political sham to cover up and to get access via the regulatory authorities without actually having a proximate effect on the end consumer. That needs to be removed.
And what would be the incentive be for the company?
The incentive for the company so for a pharmaceutical company per se, the incentive is not merely monetary gain. The incentive of access to a lot of people, the incentive of the medicine actually transforming the industry is a huge incentive for them to invest more upon such innovations, and not just monetary. Empirical data has proved this, that it's not merely monetary gain which is being focused upon by companies which invest in certain, because of the specific nature of the pharmaceutical industry being different from a normal consumer based industry.
Here, Novartis is actually charging such a huge cost
Right.
only because of the fact the legitimacy of their drug has been established.
Right.
So why would they need to further have that incentive, because they're already charging that price? They're only one of the two companies which is actually using the technology. So what is their I got your point.
Right. The point is they need to realize that the industry which they are working in is not a consumer based industry. It's a patient driven industry where the point is that the patients do not have a choice. They have to go for the products, and they're not able to go for the products because of the affordability concern. So to increase their market share, to increase the number of consumers they get who take this particular pharmaceutical innovation into actual practice, it is important for them to realize as to how they need to cut down prices to increase access to this innovation. So if that's being realized by them, then automatically they'll be like they realized in the case of EU, right? In the EU, the regulators clearly denied this particular drug's presence, but they cut down the price by 23% just to make access being available in the EU market.
Okay, and who was bearing the cost of this 23%?
The company itself bear the cost. They flat cut down 23% to make their market presence in the EU.
Okay. Can I?
Yeah.
I have to carry on with your question.
Yes.
Right.
One clarification
Right.
first I need. I think what you said earlier was that this 23% slash was done by the regulatory body in EU, and that is why the company was not ready to enter the EU market?
Ma'am, the company, so basically the Novartis had applied, it didn't get entry. Then they cut the price by 23% along with the outcome based model, and then they got entry into the model, into the EU market. Yeah, Gilead Sciences on the other hand did not agree to cut their prices, and they still don't have entry in the EU market.
Okay, so two things.
Right.
I'm carrying forward with Shubhangi's question.
Right.
First of all, why will the companies agree to follow outcome model plus the EMI model?
Right.
Right? And because you gave an explanation that they need to realize that it's a patient-driven industry, consumer-driven industry. However, I don't think that realization is for the company to have. It is a realization for probably us to have, but not a realization that a company cares about at all. For the company, it is a consumer. It does not care whether it's a need-based product.
Right.
It is a need-based product.
Right.
But for the company, that is the best product. Because it is a need-based product, that is why it can monopolize on it.
Ma'am, you're right.
Second thing is, one thing which you had said during your presentation, and that was that the regulators also need to be liberal, because if they say, like in EU, they didn't allow Novartis to enter, and Novartis then had to face losses of certain kind of 23%, and then only they could enter. So you are proposing that there has to be a balance of certain sort, right? That's what you're proposing. My question is, quite honestly, we may not need that balance to happen. The reason being, because Novartis also has to rely on huge, and I'm going to say in Novartis language, consumer base, not patient base, consumer base, because that is how they view patients.
Right.
Yeah. So when there is a loss of such consumer base, they may consider slashing their prices, because now they are not putting a lot of money in innovation anymore.
Right.
That has been done. That was a fixed cost which has been incurred already. Right? So they can afford to slash prices.
Right.
So I guess the idea that regulatory body needs to be liberal probably is going to backfire.
Right. Your second question kind of answered the first question. Like basically, what incentive do they have to? It's because they need access to they need a consumer base for access. Hence, they need to cut down the prices. And answer the second question, ma'am. Regulators have straight denied them access, which the regulators not being liberal de-incentivizes them to invest in the market. Which because of regulators not being liberal, they don't get to enter they say that we won't get profit out of this market, so why do we invest in this market in the first place? In India specifically, a lot of pharmaceutical innovations have not gotten entry in the market, and they have not deliberately not tried to enter the market because of the fact that they know that regulators will not let them enter the market, which denies access to Indians of that technology, right? So a relatively liberal mechanism will let them get entry in the market, and once a lot of competitors get entry in the market, competitive forces of demand and supply can start playing.
Okay. First of all, there is a lot of, and take these comments as something which you have to like
Right.
develop upon.
Right.
When you say that relatively liberal, you will have to define
Yeah.
this relatively liberal that you're
Yeah.
talking about.
Yeah.